All right, folks, last lecture of the semester. You must feel good. All right, so first of all, this is control of respiration. And before I even get started, let me just remind you that the cardiovascular system is controlled in synchrony with the respiratory system. And like I've said before, there really is no sense in breathing faster if you're not going to send more blood to the lungs. And likewise, there's no sense of sending more blood to the lungs if you're not going to breathe faster, because they're intimately linked. Why you're breathing is to for oxygen to get on your blood cells, and why you're sending blood to the lungs is to pick up oxygen. So they are linked together. So what we do is uh, we synchronize the control of the two. Now there's local control and there's central nervous system control. And the big thing I want you to know about breathing is that CO2 is the biggest driver of breathing. All right. There is a thing called hypoxic drives, which where oxygen is a driver of breathing. When oxygen is the driver of breathing, we got to be careful about some things. All right, and we'll talk about that a little bit. But paramedics and healthcare professions, they've actually changed their practice from giving nasal cannulas and other delivery methods of oxygen. They've changed that to more of a blow-by of the oxygen because of this. For example, if kids are breathing on a hypoxic drive, that means the oxygen is their low oxygen is their primary reason for breathing, and you give them a breathing mask of oxygen and you elevate the oxygen in their blood, you just remove their drive to breathe and they stop breathing. So what we've done now is we've we've changed our practice and we do different delivery methods of oxygen. So our primary reason for breathing is high CO2. There is another breathing drive called, which is oxygen, but it's I shouldn't put a star there. It's secondary. The hypoxic drive to breathe, that means low oxygen drive to breathe, is secondary. CO2 is primary. All right. Our cerebral cortex can affect our breathings, and our limbic system can affect our breathing rates. That means our emotions. So lots of things can affect our breathing rates, but we have one major area in our medulla, and it's called the respiratory group. And in the respiratory group, we have a dorsal respiratory group and a ventral respiratory group. The dorsal respiratory group is the primary one, and this does inspiration. And it does inspiration for every breath you take. All right. So that's the primary group. Now, expiration is passive usually, so we don't need a respiratory group to do expiration. However, as you know, sometimes we do forced breathing. And when we do forced breathing, the ventral respiratory group is involved. It does inspiration and expiration, and it's secondary and it's forced. So that's what's going on here. So our dorsal respiratory group is involved in every single breath that you take. What happens is it's activated for about 2 seconds. And I'm going to tell you how it's activated. Okay, it's activated by the apneustic center from the pons, but we haven't got there yet. So it's activated for about 2 seconds, and then it's inhibited for about 3 seconds. And that means it's not activated by the apneustic center from the pons. And the reason why that is because the pneumotaxic center actually inhibits the apneustic center, but we're getting there. So all I need you to know for now is DRG is active for 2 seconds and inactive for 3 seconds. And this sets up our breathing rate. All right, so that's 5 seconds. And 5 goes into 60 12 times, so you would expect we'd take about 12 breaths per minute, and the range is something like 12 to 18 breaths per minute, something like that. Now, when does the ventral respiratory group come into play? It comes into play for forced inspiration and expiration. So when you're using your accessory muscles, this comes into play, and it does both inspiration and expiration. And when it does inspiration, it does a gasping inspiration. So you'll hear the gasping when the ventral respiratory group is involved. All right, so before we get to putting that all together, let me remind you that the cardiovascular system and the respiratory system are synced, And there's a local or auto regulation. That's what we're talking about here. And just look at this. First of all, let's say we're out of sync. There's a mismatch of ventilation and perfusion. Perfusion is blood flow. So if your ventilation is too low for your blood flow, or your perfusion is too fast for your ventilation, what we get is we get a local change in your CO2 and oxygen. If you're not breathing in, if your ventilation is low, your PO2 is going to go down and your PCO2 is going to go up. All right. So when this happens, when we have this mix match, the diameters of my blood vessels are locally regulated and they dilate so more blood flows in. All right. And then the pulmonary arterioles will constrict. So now the blood that comes in will pick up the oxygen. So I'll rematch or I'll synchronize my ventilation and perfusion. What this constriction does, pulmonary arteries constrict. If they constrict, I will decrease my perfusion. Because see right back here, it said the mismatch could be slow breathing or too much perfusion. Well, how do I decrease this perfusion that's high? Well, if I can decrease that perfusion that's high by constricting my pulmonary arterioles. So what I'm going to do is I'm going to increase my breathing rate and decrease my perfusion to get them to be matched. And I match them. So that's a matched ventilation and perfusion. Down here, this is a mismatch the other direction, I do believe. Yes, I am breathing too fast, or I'm not pumping enough blood to the lungs. One or the other, or both. It could be a combination of both. And if I'm not pumping enough blood to the lungs, I dilate those blood vessels and more blood comes into the lungs. Plus, I can change my ventilation rate. And this is all local regulation driven by PCO2 and PO2. So this has nothing to do with the brain. I'm always doing this. I'm always adjusting, making minor adjustments to my blood vessels to match ventilation and perfusion. So this is local or auto regulation. And then I have my central nervous system control of respiration, and that's my dorsal and ventral respiratory group. Here's what happens. My dorsal respiratory group is the primary one. That's the primary reason you breathe. And what happens is my dorsal respiratory group becomes active for about 2 seconds. 2 seconds right there. I'm getting there, but I'll tell you this, that the apneustic centers from the apneustic center from the pons is the one that activated this. It said turn on for 2 seconds. Well, it said turn on. But why is it only on for 2 seconds? Well, because still up in the pons, there's this pneumotaxic center. And that pneumotaxic center, about every 2 seconds or so, inhibits the apneustic center. I should say once every 5 seconds or so. So it inhibits the apneustic center. So the apneustic center then can't tell the dorsal respiratory group to stay active. So the apneustic center fires, DRG fires for 2 seconds, then the pneumotaxic center inhibits the apneustic and the DRG turns off. It's off for about 3 seconds. Does it say that here? No. But yes, it does. It's off for about 3 seconds. And I exhale passively. Remember, your exhalation during quiet breathing is passive. So I'm 2 seconds activated and 3 seconds off. All right, so that's the dorsal respiratory group. Now, with forced breathing, my dorsal respiratory group and my ventral respiratory group are involved. My ventral respiratory group is involved in forced breathing only. All right. So the VRG hits muscles, the accessory muscles of inhalation and exhalation, whereas my DRG only hits primary muscles of inhalation. All right. So what's going on here is this. When the DRG is active, the VRG expiratory center is inhibited. That says it right here. Well, that should make sense to you, because if I'm inhaling, I don't want to exhale. I got to do one or the other. So when the DRG is inhaling, and the VRG can be inhaling. Remember, the VRG can inhale, forced inhale. So when I'm doing forced inhalation, my VRG exhalation is inhibited. So I do this forced inhalation right here. And now my DRG, the inspiratory center of my DRG, and it only has an inspiratory center. Remember, the DRG doesn't have an expiratory center. These are inhibited. My DRG inspiratory center are inhibited, and my VRG expiratory center is active. VRG active expiratory center. And then I exhale, and this is forced exhalation. So I just keep going back and forth during this forced breathing is where my DRG and VRG inspiratory centers are active and my VRG expiratory center is inhibited. I inhale. Switch. My DRG and VRG inspiratory centers are inhibited and my VRG expiratory center is active. Switch again, and I just keep going back and forth. That's the collage showing you that. So remember, VRG is only active during forced breathing. Now I do have these other centers that I've already talked about a little bit. The pneumotaxic center inhibits the apneustic center. The apneustic center activates the dorsal respiratory group. All right. So that's why the DRG is active every 2 seconds, then quiet for 3, because of this apneustic center telling it to. But the apneustic center doesn't constantly tell it to because the pneumotaxic center inhibits the apneustic center every 5 seconds or so. So that's how I set up my my breathing rate. Okay, we're having this another complex. It's not shown. Oh yeah, it is right there. This is called the pre-Botzinger complex. It's also called the central pattern generator. And we don't know a lot about it. So fortunately for you, because 10 years from now when I'm teaching this, I'll probably have to teach a lot about it because we'll know a lot about it. But right now, it's not really well understood. So I'll just suffice it to say that there's this other area right below the DRG and VRG in my medulla that's called the pre-Botzinger complex. There's the word right there. It's involved in breathing. We know that. We know it's involved in a pattern, the setting of a pattern of breathing. We know that. But we don't know the mechanism, and we're not sure exactly how it works. So there you go. You're not going to have to learn a lot about that. Now, what controls the pneumotaxic center and apneustic center? And the answer is CO2. Remember I told you CO2 is the primary drive to breathe? Well, we have chemoreceptors, both peripheral chemoreceptors in our aorta and carotid arteries, and central CSF chemoreceptors. And these chemoreceptors detect how much CO2 is there, and therefore indirectly they detect pH. What do I mean indirectly? Well, remember this. Well, if I have high CO2, then I'm going to have high hydrogen ions, right? That's low pH. So these chemoreceptors are detecting CO2 and indirectly pH. And what they do is they go down and they affect the pneumotaxic centers and the apneustic centers. Then the pneumotaxic center inhibits the apneustic center. But what if I could inhibit the pneumotaxic center? And therefore I'm not inhibiting the apneustic center and I take a big deep breath in. So if I have high CO2, I'll come over here and I'll inhibit the pneumotaxic center, which removes the inhibition from the apneustic center, which now goes down and tells my DRG, well, it actually will tell my VRG. It hits both of them. They're not isolated in space. To take a gasping breath in. And why? Because my CO2 is too high and I want to start breathing faster. So that's how that works. I have chemoreceptors that are affecting my brain to breathe faster with high CO2. This is just showing you how the neurons, how the nerves get to the muscles. The phrenic nerve hits the diaphragm, and there's other nerves that hit your intercostals. There's a collage for you. All right, now this is an arterial blood gas story right here. What happens is, it's actually what we just talked about. If I'm in homeostasis, my CO2 is normal. Oh, I'm hypercapnic. Hypercapnia means high CO2. If I am high CO2, first of all, my arterial chemoreceptors detect it, and my central chemoreceptors detect it. They detect high CO2 and low pH. Through the pneumotaxic, apneustic, DRG, and VRG, they increase respiration. If I increase respiration, I lower CO2, which is good because the whole thing that started this was a high CO2. Likewise, going the other way. For some reason, I'm hypocapnic. I have low CO2. My chemoreceptors detect this. They inhibit my respiratory muscles. I decrease my respirations, which leads to an increase in CO2, which is good because the whole reason I started this was my CO2 was low. So this is the collage. You need to understand this homeostatic loop controlling CO2. All right, there's a baroreceptor reflex that prevents my lungs from overinflating. So I can only take in so much. And that's called the Herring-Brewer reflex. As my lungs inflate, there's a nerve, there's a receptor that senses that stretch, and it sends a signal to stop inhaling. So this is called the Herring-Brewer reflex. It prevents overinflation. All right. And we have some protective reflexes. These protective reflexes lead to things like sneezing and coughing and hiccups. So things that are really irritating. I had hiccups the other day and I was trying to think of why I had them. Couldn't remember what I concluded, but so these are some of the protective reflexes in our respiratory system, and they keep toxins and chemicals out of our lungs and help to protect our lungs. All right, I think we're just about done with this last section. Make sure you read on this about the pneumotaxic and apneustic centers. By the way, good, I'm glad that's here. They're called pontine respiratory centers because they're in the pons. So the pontine respiratory centers are the pneumotaxic and apneustic. So make sure you realize, don't let that word throw you. And the ventral and dorsal respiratory groups are in the medulla. This is showing you the chemoreceptors and what they're doing to your breathing. Obviously, if your oxygen is too low and your CO2 is too high, you're going to increase your breathing. If the other is true, if your oxygen is too high and your CO2 is too low, you're going to decrease your breathing. And you also have some stretch, like the Herring-Brewer reflex going on in your lungs, that can affect your breathing. Okay, this picture is not in your book, but it says the same thing we just said. It said if your CO2 is too high, you're going to slow down your breathing, or increase your breathing. I'm sorry, I just said that wrong. If your CO2 is too high, you're going to increase your breathing, increase ventilation. If your CO2 is too high, you're going to increase your ventilation. And this is showing you where those peripheral receptors are. They're in the aortic bodies right here, and they're in the carotid bodies right there. That's where they're located. And there's nerves hooked to them that go up into your pons and medulla oblongata to affect your breathing. So this backs off and gives you a bigger anatomical picture of those bodies, the aortic bodies and carotid bodies. All right, this is just talking about some of the things that affect our breathing. Well, there's two main. Well, there's actually four main classes. Actually, let me back up. We can talk about. No, let me not do that. There's two main classes of diseases here. We can have obstructive diseases, or we could have gas exchange diseases. That means the air is getting there, but the exchange is not going on. So this you can imagine is a membrane issue. It's an alveolar issue. Whereas as the obstructive is anything with bronchial constriction, restrictive pathways, like asthma. So that would be asthma, things like that. So we have obstructive and we have gas exchange. Now let's talk about this for a second. With chronic bronchitis, this can lead to some obstructive problems, not getting the air in. So you have airway obstruction or air trapping. So that's not getting in there. So you have difficulty breathing. That's dyspnea. Whereas with emphysema, the air is getting in there, but your alveoli have fused. So you have a lower surface area to volume ratio with emphysema. You really have destruction of alveoli, and they actually fuse. But numerous small things have a greater surface area to volume ratio than fewer large things. So with emphysema, you lose your surface area, and therefore you lose your gas exchange ability. Some other things that can happen with your breathing is connective tissue diseases like lupus. It's an autoimmune disease that hits your connective tissue. They can change the compliance of your lungs. Remember what compliance is. High compliance means it's easy to breathe, and low compliance means it's hard to breathe. So some diseases can change connective tissue and change your compliance. All right, and let's talk about some changes in the respiratory system from fetus to adult. So the first breath you take is likely, which none of us remember, is likely a pretty difficult breath because we're just starting to make surfactant just before we're born, and our alveoli are all collapsed. But a couple things happen when you take that breath. Well, first of all, you're out of the uterus now, so a that's a pretty traumatic thing. Another thing is that the childbirth itself was traumatic for you, so you released epinephrine as a baby. Epinephrine led to a surfactant surge, so that first breath becomes a little easier because you have a surfactant surge, which allows your alveoli to expand. So the first breath occurs and you take your first breath. Now what that does is by expanding your thoracic cavity, now blood starts to flow back to your heart more rapidly because your superior vena cava has low pressure and venous blood starts flowing back. What does that do in your heart? Closes your foramen ovale. More blood flowing back to your right atrium closes your foramen ovale. In your left atrium, by the way. More blood back to your right atrium and left atrium. And your ductus arteriosus becomes the ligamentum arteriosus. All right. Look at it says right here. First breath pulls blood into the pulmonary circulation. Close it. Actually, I just read. I actually didn't read it to you. I just saw that it was written there after I said it to you. So it's written there for you as well. Now, what happens as you get older? Your collagen and other elastic tissues start becoming less flexible, and it lowers compliance. So you get a lowered compliance as you get older. And this just is a graph showing as you get older. Okay, the big thing about this chapter is the apneustic center, the pneumotaxic center, the dorsal respiratory group, and the ventral respiratory group. That's the big things about this chapter. That's it, folks.